my casual attire. I'm at a different meeting in Chicago, and then I'm
We are live.
Good evening, everyone. Welcome to our next session, which is on anti-VEGF injections and where are we in 2025. This discussion will be moderated by Dr. Mahesh B. Shanmugam, sir, and along with them, we have Dr. Suneet Garg and Dr. Lalit Verma as our esteemed chairpersons. I now invite Dr. Shanmugam, sir, to introduce the speaker and the chairperson and to commence this session.
Thank you, Dr. Prapti, for the introduction. So I invite Dr. Sunil Garg, the president of ASRS, to give the opening remarks.
Shanmugam, it's really a pleasure to be here. We've enjoyed the partnership of the American Society of Retina Specialists with the All Indian Ophthalmology Society, as well as the Vitreoretinal Society of India. We've learned a lot from our colleagues in India, and we're delighted to be able to share some of the things that we're doing here in the US with you. We have a fabulous program today with a bunch of our young up-and-coming faculty who really have done a lot of work in this space, and I think have a lot of useful clinical insights for us as well. We look forward to a lively discussion. As questions come up, please feel free to share them. We'll do our best to answer them as we go along. I'll turn it back over to Dr. Shanmugam.
Thank you so much. I thank the ASRS for coming forward to help us and make it a very lively program. Let me introduce the faculty. So we heard Dr. Sunil Garg. He is a professor of ophthalmology and a co-director of the Retina Research Unit, and he works at the Retina Services of the Wilsey Hospital. I'll be presenting the faculty as they appear in the order of presentation as the discussants as well as the speakers. Dr. Chirag Shah, the young Dr. Chirag Shah is the co-director of the Vitreoretinal Surgery Fellowship at Ophthalmic Consultants of Boston and Tufts, assistant professor at Tufts School of Medicine. He is a lecturer at Harvard Medical School and investigator for numerous clinical trials. And interestingly, he teaches a financial planning course at Harvard Medical School as well. Maybe we should attend that course as well sometime. Dr. Joshua, he's a vitreoretinal surgeon with the Mid-Atlantic Retina and also the Retina Service of the Wilsey Hospital. He's an assistant professor of ophthalmology at Thomas Jefferson University Hospital. He has done his postgraduate training, the vitreoretinal fellowship at the Bascom Palmer Eye Institute and ophthalmology residency in the Wilsey Hospital. And there's a very crowded slide which shows the achievements of Professor Vishali Gupta. She is from the PGI Chandigarh. She is currently the president of the International UVAT Study Group, vice president of the Vitreoretinal Society of India, past president of UVAT Society of India. And she has numerous publications and presentations, and of course, like a list of huge number of awards as well. Welcome, Dr. Vishali. Dr. David Zhu, he is again with the Mid-Atlantic Retina, and he specializes in vitreoretinal surgery, and he is with the Retina Service of the Wilsey Hospital, assistant professor of ophthalmology, Thomas Jefferson University Hospital. He has done his ophthalmology residency at Jules Stein Eye Institute, UCLA, and vitreoretinal surgery fellowship at Wilsey Hospital. Welcome, Dr. David. Dr. Muna Bende will be joining us very soon. She is a senior consultant and deputy director of the vitreoretinal services at Shankar Nethralaya, Chennai. Her special interests are medical retina, inherited retinal disorders, and retinal imaging. She teaches and trains ophthalmology residents, fellows in medical retina and vitreoretinal surgery and optometrists. She has around 110 peer-reviewed publications, and once again, she is also blessed with many awards over the past many years. Young Dr. Meera Sivalingam is with Mid-Atlantic Retina, and she specializes in adult and pediatric vitreoretinal surgery. She works at the Retina Service of Wilsey Hospital. She is an assistant professor of ophthalmology at Thomas Jefferson University Hospital, and she has pretty much done all her ophthalmology education at Wilsey Hospital. Welcome, Dr. Meera. Dr. Rohan will be joining us, hopefully. He is an additional professor of ophthalmology at RP Center, and he specializes in vitreoretina and uveitis, and is the associate editor of the Retina section of the Indian Journal of Ophthalmology. He has more than 280 PubMed index publications, and he is an editor of textbook on ocular tuberculosis, and he is an investigator in multiple international multicentric trials. Dr. Raja, he is a retina faculty with Delhi Prasad Eye Institute. Welcome, Dr. Raja. Dr. N.S. Muralidhar, he comes with many years of experience. He started the Retina Institute of Karnataka in Bengaluru in 1996. He He is the former president of Karnataka Ophthalmology Society and of Vitreoretina Society of India. He completed his MD in the All India Institute of Medical Sciences, and he has done his fellowship in vitreoretinal surgery in Sydney. Young Dr. Meenakshi is a registered with the vitreoretinal services at Shankara Eye Hospital, Bangalore. She has completed ophthalmology training at Shankarnetla, Chennai, and she got the best outgoing postgraduate. She is a fellowship in vitreoretina and ocular oncology from Shankara Eye Hospital, Bangalore, and she has numerous publications in reputed journals and is actively involved in research work with a special interest in ocular oncology. She is also presented in multiple national and international conferences with awards to her credit. Dr. Pradeep Sagar once again works with me. He has completed his fellowship in VR and ocular oncology, Shankara Eye Hospital, Bengaluru. He is a VR consultant at Shankara Eye Hospital, Shivamogga, and at his young age, he has got more than 63 publications and 15 textbook chapters. Dr. Srimakpurti Sriram, he is one of my young colleagues. He has completed his MD at AIMS, and he is a consultant with one of our hospitals in Hyderabad. He has around 28 publications and author of 2 textbook chapters, and his areas of special interest are imaging in retina and macular surgeries. And he has again received many awards so far. Dr. Gaurav Sir, hopefully he'll be joining us, but very early for him. He works with the West Coast Medical Retina Group. He has numerous awards and honors, the Lifetime Achievement Award from the AAO and the Chartered Inductee of Retina Hall of Fame, who is in top 150 retina specialists of 2016. He's got more than 200 publications and 17 book chapters, and he's likely to be, he's the future president of ASRS, and probably starts in 2027. So Lalit Verma, once again, is a very crowded slide, indicative of all his achievements. He is the Congress president of the APAO ASRS, APAO AAOS, which is to be held in April this year. He is the Secretary General of South Asian Academy of Ophthalmology, President of the All India Ophthalmology Society, and Director of Vitreoretinal Services, Center for Sight, New Delhi. He has numerous publications and numerous awards, and if we go through all this, I'm sure we'll take half of our symposium time. Welcome, Dr. Lalit. And so that brings us, so we have very elite and erudite faculty, and we look forward to a great webinar. And we'll start with, stop sharing my slide. So the flow of the presentation will start with Dr. Chirag Shah, who will be speaking to us on the future of the anti-VEGF, if we can try to increase the duration of the injection duration between the injections. And this talk will be discussed by Dr. Sunil Garg once Dr. Chirag finishes. And I invite all the panelists to please go ahead and join the discussion. Dr. Chirag, please.
Dr. Shanmugam, thank you so much for inviting me. It's an honor to be part of such an esteemed panel. I don't have a lot of time. I have about 8 minutes, and I'm going to try to cram in a lot of information during that time. Tonight, or I guess this evening, we'll discuss tyrosine kinase inhibitors and gene therapy as ways of extending anti-VEGF treatment duration. Specifically, we'll speak about vorolanib, which is a product from EyePoint, tyrosine kinase inhibitor, as well as axitinib, which is a similar product from Ocular Therapeutics. With regards to gene therapy, there's a lot to cover there, and we'll only have a short time, but we'll talk about one gene therapy product called Ixo-vec by Adverum. So as you all know, there's a significant need for more durable therapies in wet AMD. The more we treat patients, the better they do in general. And patients can be lost to follow-up or non-compliant, and as a result, their vision can suffer if we undertreat them, as we often do in the real world. Our current anti-VEGF therapies target extracellular VEGF ligands, whereas tyrosine kinase inhibitors, they work intracellularly to inhibit the VEGF receptors themselves. We'll talk about two. So the first is vorolanib, which is a tyrosine kinase inhibitor. It's a product of EyePoint Pharmaceuticals. And the way that this works, it's infused into this Duracert implant, which is injected into the eye with a 22-gauge needle, and it lasts for at least 6 months. It slowly eludes medication for 6 months. The implant itself dissolves after about 9 months. Ocular Therapeutics has developed a medication called axitinib, which is 100 times more potent for the VEGF receptor 2 compared to vorolanib. And this is injected through a 25 gauge needle in a hydrogel. And so this also dissolves at around 9 months, and it elutes medication for at least 6 months. So let's talk a little bit more about the iPoint trial looking at vorolanib. They compared 2 different doses of the medication compared to aflibercept. This is a phase 2 study. As you can see in the gray box in the lower right-hand corner, there were retreatment criteria that were somewhat strict compared to real-world retreatment criteria. They required a significant amount of recurrence of leakage or loss of vision before allowing a rescue injection with aflibercept. What they found was that the visual outcomes were similar between their TKI product and aflibercept. There was also a pretty strong anatomical response. I will note that it's not clinically significant, but there was a little bit more leakage in both TKI arms compared to the aflibercept arm. And not surprisingly, we're seeing some sawtoothing with the aflibercept arm because it's dosed every 8 weeks. And so the leakage increases at around week 4 and then decreases at week 4 and increases at week 8 at the time of retreatment. But with the strict retreatment criteria, 63% of eyes were supplement-free at month 8, which is pretty good. And this amounts to a reduction in treatment burden by 85 to 89% compared to how frequently patients were treated prior to receiving an implant. There were no concerning safety concerns. There were no cases of endophthalmitis, no vasculitis. There's no migration into the anterior chamber. And interestingly, you would think patients would see this implant floating around in their eye. Patients didn't really notice that. It's kind of sunk to the bottom of their vitreous cavity. The Ocular Therapeutics product was tested in 2 phase 1 clinical trials, and they were so impressed with their phase 1 clinical trials that they skipped phase 2 and they went directly to phase 3. And we'll talk about those 2 phase 1 clinical trials right now. Both iPoint and Ocular Therapeutics are currently in phase 3 testing their individual products. The first phase 1 trial conducted by Ocular Therapeutics was done in Australia. It was a dose escalation study. It was only 23 patients, so a very small study. But in this small study, again, with very strict retreatment criteria, they found that 60% of patients did not need any rescue anti-VEGF treatment for 6 months. And in fact, the median time to first rescue was 7 months. There was good improvement of the central subfoveal thickness, and there was stability of the best corrected visual acuity. You can see this case example to the left of your screen is a patient enrolled in the study. They received 1 single TKI injection, and you can see that they had disease control by month 2, and they required no additional rescue treatments out to 11 months, just with 1 TKI injection. Similar to the iPoint product, there were no significant adverse events. The results of this initial phase 1 study led to a second phase 1 study, which is also a small study conducted in the US. There were 15 patients randomized to the Ocular Therapeutics product compared to 5 patients in the aflibercept arm. And in this study, patients were treated with the TKI, and then that was followed by a single Eylea or aflibercept injection, and thereafter patients were just treated as needed based on their rescue criteria, which you can see in the purple box below. There was an 89% reduction in treatment burden with the TKI. And indeed, at 12 months, 60% of patients did not require any additional anti-VEGF treatment. There was stability of visual acuity, stability of the central subfoveal thickness comparable to that with aflibercept alone. There were no significant safety concerns. There was 1 case of endophthalmitis in the implant arm, but this happened after a planned aflibercept injection. That's a very quick summary of where we are with tyrosine kinase inhibitors or TKIs, both currently in phase 3 testing. And both seem promising in terms of trying to elongate the duration in between anti-VEGF injections. Let's briefly talk about gene therapy. There are several gene therapy products that are currently in the pipeline. We'll talk about ADVM22, which is a AAV2 vector, which codes for a sequence that essentially creates a aflibercept inside the eye. And so it's ideally it's a single injection, and then you'll have this aflibercept machine in the eye forever. And so an example of a patient treated with this product is in the lower right-hand corner of your screen. This patient was enrolled in the phase 1 optic study, and you can see they had significant subretinal fluid and macular edema at baseline. They received a single gene therapy injection. It's called Ixo-vec. And even after 3 years, there was no recurrence of exudation, and they maintained control of their wet AMD. One major problem with all gene therapy is the risk of inflammation. And there was, of course, significant inflammation in the phase 1 optic study as well, both anterior and posterior inflammation. These encouraging results led to a phase 2 study called the LUNA study, which compared 2 dosages of gene therapy, but also, interestingly, they randomized patients to 3 different regimens to try to immunosuppress eyes, either with topical, intravitreal, or oral steroids in an effort to try to control inflammation. What they found is that there was a 93% reduction in treatment burden with gene therapy. There was stability of visual acuity, stability of central subfoveal thickness. And what they found was that those treated with intravitreal dexamethasone and topical difluprednate eye drops fared better in terms of inflammation. 90% of these patients had little to no inflammation. So that will be the Achilles heel, I think, of gene therapy, is trying to figure out how we can control the inflammatory response. Thank you so much for your attention and for having me this evening.
Thanks,
Thank you
Chirag,
so
for a
much,
great
Chirag.
talk and a great
Please go
overview
ahead.
on this subject area. One of the things that I'm curious about is, we keep working on durability as our major endpoint for these studies because we know that's hard for patients to come in regularly. And both TKI inhibitors are looking for durability in a 6 to 9 month time frame. Gene therapy potentially for a 2 to 3 or more year time frame. How do you think all this is going to shake out for us? I'm just going to ask you to kind of forecast the future a little bit. And do you think there'll be different drugs for different patients, or do you think that, it'll be, we'll try this, and if it doesn't work, we'll then try this and see what works for a particular individual? And do you think our injections are going to go away, that these treatments are going to work so well that our workflow will change as well?
I think there is a risk that we could all be unemployed in the near future, but there is still some time, I think, before we get there. But a lot of it is a race to the finish. So TKIs are by far more advanced in terms of their pipeline and I think their acceptability compared to gene therapy. So I think we'll see TKIs first. Both drugs that I mentioned are in phase 3 testing. I think that they will likely extend, but it's not going to be for everyone. I think retina doctors already are turning a little bit into oncologists, where we have a wide armamentarium of medications, which is getting wider as we speak. And we will kind of pick and choose based on the individual patient. If you have a patient on bevacizumab who's every 3 months and has been happy for the last 10 years, there's no need to really rock the boat. But we all have patients that have much more aggressive wet AMD and may need additional kind of supplemental help with the TKI, for example. And so I think it's going to be tailored. The other piece is we also have to think about the cost of these medications. Gene therapy is likely going to be $50,000 or more, and it's not easy for a phakic patient with glaucoma to get an intravitreal dexamethasone implant at the time of gene therapy, for example, given the risk of glaucoma and cataract formation. So we really are going to be tailoring these drugs, but I do think for the right patients, these drugs will be important. And I think injections won't necessarily go away. In both of these drug products, injections are important. The other thing that's not going to go away is monitoring. These patients came into the offices to be monitored. We may end up seeing an increase in home OCT and home monitoring as a way to see if patients do require rescue treatment. And so I think it's interesting. We still have a ways before we get there, so we'll still have jobs. But I do think that both of these products will likely be integrated into our practices. Gene therapy will have to be a little bit more mindful of the inflammatory side effects because that can be quite significant depending on the patient and depending on the product.
Thank you, Dr. Chirag. Are there any other comments or questions from the panel? I have one. Are these gene therapies, it's gene agnostic? Does it work for all patients with AMD, or is it like, does it work for PCV as well, or only with AMD?
I believe this is gene agnostic. So it's coding for so the particular product we just spoke of codes for a protein that's essentially a aflibercept that's translated inside the eye for it seems for 2 or 3 years, maybe longer. But these are agnostic, and so in theory, this could be used for other disease states that benefit from anti-VEGF therapy, not just wet AMD.
The TKI
I just had
inhibitor, the studies have been only for the AMD, or is it for other diseases also? That's the TKI inhibitor.
So TKIs are also being tested for diabetic edema, diabetic retinopathy right now. I didn't present that data because we were focusing on wet AMD. But yes, just like most drugs, it'll start with wet AMD, then it'll go to diabetes, and then it'll go to RVO, and then we'll use it for everything else that we want to use it for off label. But that's usually the sequence. But yes, TKIs are being tested in diabetes right now.
Thank you so much. Dr. Muralidhar, you wanted to ask?
I just wanted to ask Chirag whether the TKIs were used in conjunction with the anti-VEGF in the study, or they were in the arm, the TKI arm. Was concomitant use of anti-VEGFs also done?
Yeah, great question. So there's two products. So the iPoint product, patients received 3 loading doses of aflibercept in the DAVIO 2 study. And then at month 3, they were randomized to the vorolanib implant or a sham implant. So that's the iPoint study. So they did get 3 initial anti-VEGF treatments. And then with the ocular therapeutics study, again, very, very small study. The phase 1 was dose escalation, but the phase 2, only 15 patients were treated, but they received initially the TKI implant, and then after that was followed by a single aflibercept injection, and then thereafter they were treated as needed. So there is some anti-VEGF treatment in both of these studies, and I do think that we'll see, but in real life there'll likely be something similar where early on in the treatment we want to hit them hard with anti-VEGF to try to control the disease, and then the TKI is intended to kind of for maintenance in patients who respond well to anti-VEGF treatment.
Dr. Munna? You're muted, Dr. Munna.
No,
Now we can
that
hear.
was a very nice talk, Dr. Shah. Looking into the future, we are already confused which anti-VEGF to use. Which is the group of patients where you think TKI inhibitor would be beneficial, and which one gene therapy?
Excellent question. My crystal ball is a little cloudy, it's just like all of ours. But I think for those patients who are kind of stuck on Q4 weeks, Q5, 6 weeks of anti-VEGF therapy, still with active exudative disease, I think those are the patients that are going to be more motivated to consider a TKI in an effort to try to extend the interval in between shots. We're probably not going to get to 6 months in those patients who have very aggressive disease and significant exudation. As I said earlier, I think the patients who are already on Q16 weeks of Eylea high dose or even bevacizumab, I don't think those patients have really any reason to change what they're doing because they're already spaced out far enough. So I think it's going to be the more aggressive eyes. And just like we see with other medications, those aggressive eyes tend to not respond quite as well as the average eye. Likewise with gene therapy, I think at the moment, I think inflammation is a significant concern. I didn't talk about side effects of glaucoma from the intravitreal steroid treatment that many of these eyes are receiving. And so we have to, I think if gene therapy can control can better control inflammation, I think that'll be a more intriguing option. Personally, I think what's going to happen is that TKI is going to win the race in terms of getting to market first. They're not too far off, and they're already in phase 3. Again, Ocular Therapeutix doesn't have any phase 2 data, so we might find some surprises with that drug just because it hasn't truly been tested yet. But EyePoint has a large phase 2 study that they're building on. So I think at least EyePoint and maybe Ocular Therapeutix will have a drug to market in the next few years, which will beat gene therapy. And then I think what we'll see is adoption of TKIs for our more difficult to treat eyes, the eyes that require more regular treatment.
Thank you, Dr. Chirag. Are there any other questions? If none, thank you so much for joining us early in the morning. I believe you have to leave. We would have loved to have you in the session subsequently as well.
I apologize. I have another commitment, but thank you so much for having me. And it was a pleasure joining you. Thank you.
Thank you so much for your wonderful lecture. I will move on to our next lecture, which will be by Dr. Joshua. He'll be speaking to us on the new versus established anti-VEGF, because as we have heard from Dr. Chirag, we keep getting newer anti-VEGF every 6 months or so. Is one better than the other? Is there a reason to switch from one to the other? Is what Dr. Joshua will be speaking to us on. Dr. Joshua.
Great. Thank you so much for the opportunity to participate in this symposium. First, let me just ask, can everybody see my screen? I want to make sure I'm sharing it correctly.
Yeah,
okay,
we can see your screen.
Wonderful. Thank you. So I'm going to be talking about the new versus old anti-VEGF medications. These are my financial disclosures. So I'm briefly going to walk through the evolution of our anti-VEGF medications for context here, starting with bevacizumab, which became available in 2005 and really revolutionized our ability to treat certain retinal conditions. This is a full-length monoclonal antibody. It binds to VEGF-A and inhibits VEGF-A molecules from binding to their native endothelial cell surface receptors, as you can see in the cartoon to the left. A year later, ranibizumab became available. This is an antibody fragment. It's significantly smaller than a full-size antibody, and the smaller size is thought to help facilitate retinal penetration. In 2011, 2 milligram aflibercept became available. This is an IgG backbone fused to VEGF receptor sequences. So this is a decoy receptor that binds to VEGF-A with greater affinity than natural VEGF receptors, and therefore prevents VEGF from binding to its native receptors. It has a higher binding affinity than bevacizumab or ranibizumab. Brolucizumab became available more recently in 2019. This is a single-chain variable fragment, which is the smallest functional unit of an antibody, and this small molecular size is thought to enable more rapid and even tissue penetration, and the lighter molecular mass means there's a higher concentration of molecules. This is a 13.3 times higher molar dose than 2 milligram aflibercept. The Hawk and Harrier trials showed superior anatomic outcomes and longer durability compared to 2 milligram aflibercept for patients with wet AMD, but there's a higher risk of intraocular inflammation, including retinal vasculitis, which has really limited the use of this medication, at least in the United States. So faricimab is one of our 2 new agents. This is a novel bispecific monoclonal antibody that targets 2 pathways. So VEGF, just like the other medications we were talking about, but also angiopoietin 2 or Ang2. So what does Ang2 do? Well, Ang2 binds to and inhibits the Tie2 receptor. This leads to destabilization of endothelial cell tight junctions, leading to vascular leakage. Ang2 also upregulates VEGF receptor 2 expression, so it increases cell susceptibility to VEGF-A. And the cartoon on the right here is showing that Ang2 is upregulated in states of hypoxia. So this dual mechanism of VEGF and Ang2 inhibition is hypothesized to achieve greater efficacy and longer durability. Faricimab also has a 2.3 times higher molar dose than 2 milligram aflibercept. I'm not going to dive deep into clinical trial design in the interest of time, but there's a few key things I want to point out here Tenaya and Lucerne were the wet AMD trials for faricimab. Patients were randomized to faricimab up to 16 weeks or 2 milligram of aflibercept every 8 weeks. In the second year of the trial, the faricimab arm essentially was on a treat and extend regimen. And so here's the main finding: comparable vision gains, but fewer injections. In the second year of the trial, when the faricimab patients were treat and extend, they received half the number of injections as the aflibercept patients, but maintained the same vision. Comparable CST reduction at 2 years as well, but again with fewer injections. Faricimab was also associated with greater CST reduction during the head-to-head dosing phase in the beginning of the trial. Well, how about durability? As Dr. Shah and Dr. Garg already mentioned, this is what we're after now because the drugs that we have work well for most of our patients. We need drugs that last longer. So 74 to 81% of the faricimab patients in Tenaya and Lucerne ended the trial at 2 years on a Q12 or Q16 week interval. This is good durability data for wet AMD. Other post-hoc analyses showed faster absence of fluid with fewer injections, greater reduction in PED thickness, and fewer patients with serous PEDs at week 12. These are other markers of exudation. So Yosemite and Rhine were the DME trials for faricimab. Patients were randomized to faricimab every 8 weeks, faricimab treat and extend, or what they call PTI, or aflibercept 2 milligrams every 8 weeks. And again, comparable vision gains, but with fewer injections in the patients in the faricimab treat and extend arm. Comparable CST reduction as well, but again with fewer injections. Faricimab also showed better drying at 2 years. The green and blue bars here are the faricimab arms. The gray bar is the 2 milligram aflibercept arm. And you can see that there's a higher percentage of patients in the faricimab arms who were DME free at almost every time point. What about durability? So this pie chart shows the last interval of patients in the faricimab treat and extend arm at 96 weeks, so at 2 years, and 78% of patients were on a Q12 or Q16 week interval. Good durability data for DME as well. Other post-hoc analyses showed faster drying with fewer injections, a higher proportion of patients with resolution of macular leakage at week 16, greater reduction in hard exudate volume and count, and reduced risk of epiretinal membrane formation, which is a biomarker of fibrosis. But clinical trials are not the real world. We know that in the real world, patients receive fewer injections and often have worse vision outcomes. And clinical trial patients are often treatment naive, as in Tenaya and Lucerne, or can be previously treated but have a washout period, as in Yosemite and Rhine. But in the real world, many of us are using our new medications first for our most treatment-resistant patients. So how does faricimab do for treatment-resistant patients? This is some data published at Wills Eye. My colleagues looked at 218 patients who were previously treated with anti-VEGF for wet AMD, but who were then switched to faricimab. They found a non-significant trend towards improved vision, but keep in mind there's a selection bias here for treatment-resistant eyes who have probably already reached visual stability. But after a mean of 34 prior anti-VEGF injections, they saw anatomic improvement after just one faricimab injection, with continued improvement with subsequent injections. FAR Retina is the largest real-world study on AMD and DME patients receiving faricimab. Vision improved in treatment-naive eyes and was stable in previously treated eyes with AMD and DME. But CST improved in eyes with AMD that were treated with other anti-VEGF agents and then switched to faricimab. So in other words, faricimab had better anatomic outcomes here, and that's true for DME as well in the real world. What about durability? You can see that patients received fewer injections in the latter 6 months in orange in these bar graphs compared to the first 6 months in blue in both treatment naive and previously treated eyes with wet AMD and DME. So this is a marker or a signal of better durability. And finally, moving on to our second new drug, this is high dose or 8 milligram aflibercept. It's the same molecule as 2 milligram aflibercept, but with a higher concentration and improved stability. It has a 4 times higher molar dose, which is projected to allow longer treatment intervals. And it is, of course, injected at a higher volume, 70 microliters compared to 50 for our other agents. Pulsar was the wet AMD trial. Patients were randomized to regular dose or 2 milligram aflibercept every 8 weeks, or high dose aflibercept every 12 weeks, or high dose every 16 weeks. And in the second year of the trial, the high dose groups had the ability to extend at certain visits and based on certain preset criteria, of course. And again, comparable vision gains for high dose of aflibercept, but with fewer injections compared to regular dose. Comparable CST reduction, but fewer injections. Well, how about durability? So if you look at the high dose group that was randomized to every 16 weeks, 79% of those patients ended the trial on a 16-week or longer interval. So that's really good durability data for wet AMD. And 31% met criteria for extension to 24 weeks. That's almost 6 months. I say met criteria because this would have been their next interval had the trial essentially not run out of time. Photon is the DME study. Similarly designed, patients were randomized to regular dose of aflibercept Q8 or high dose Q12 or high dose Q16, and the high dose arms had the ability to extend in the second year of the trial. And similar findings, comparable vision gains, but fewer injections. Comparable CRT reduction, again, fewer injections. Well, how about durability for DME? So if you look at the high dose aflibercept group randomized to every 16 weeks, 89% of those patients completed the trial on a 16-week or longer interval, and 32% met criteria for extension to 24 weeks. This drug is still new. There's actually not much real world data that I was able to find. But the main conclusion here is we've got 2 new anti-VEGF options, both with better durability than our older agents. Thank you.
Thank you so much, Dr. Joshua, for a wonderful lecture. We are still stuck at the 3 to 4 months. It looks like we have to keep repeating the injection. I invite Dr. Vishali to discuss the presentation. Dr. Vishali.
Thank you, Josh. Josh, as you said, real world is very different from the world of the clinical trials. And we in India, coupled with the real world challenges, have an added challenge of patient paying from their pocket because many of them would not even have insurance. So I have a couple of questions for you. When you switch your patients who are currently stable but would like to shift to faricimab for the duration, would you still give them 4 loading doses?
Yeah, so that's a very good question. I really do not follow the loading doses done in the clinical trials for patients that are switching from one drug to another. What I typically do, and there's obviously a lot of variability and everyone has a different system, I usually keep them on the same interval of the agent that they were getting. And then if they're doing well or doing better, then start to extend. So let's say I have them on bevacizumab every 6 weeks. I'll start them on faricimab at 6 weeks and then take it from there.
Okay, that's helpful. And my second question to you is regarding brolucizumab. You know, we all understand the effect it causes and the occlusion and hemorrhagic vasculitis, and it scares us. But there have been lots of reports saying that it's very safe to use as first-line therapy because some populations probably behave different from others. I don't think there are per se any pharmacogenetic studies, but what is your take on using brolucizumab in the era where we do have alternative newer drugs available as first line of therapy?
Right. Yeah. So I personally do not use it much. And I'll be honest, I have never initiated a patient on it. The patients, I have a very small subset of patients who get it, and they're mostly patients that I've inherited from other physicians who are already on it, and they are tolerating it well, so I haven't switched them to another drug. As you said, it works well, and it is a minority of patients, of course, that get this severe inflammatory reaction. So I certainly do not think it's unreasonable to use. But I think we have other agents that we know also work well and seem to be less inflammatory. So I personally feel more comfortable using those. Although there are reports of vasculitis with all of these drugs, including the newer ones. So something, of course, to be mindful with no matter which agent you're using.
And where would you place Eylea, aflibercept 8 milligram? Would it be your first line of therapy for those patients you are planning? And does the presence of PCV or a large PED influence your decision on which anti-VEGF to start with?
Yeah, so good question. Well, in the US, we also have financial constraints, and a lot of our insurers require that we start with bevacizumab, and then sort of progress through, depending on the insurer, a specified list of agents. So some of that is out of my control. For that reason, I end up starting a lot of my patients on bevacizumab and switch them as necessary. For PCV, so the Pulsar trial did look in a post-hoc analysis at the subset of patients with PCV, and it seems to work well. I asked the company if they have data on how many patients had breakthrough macular hemorrhages who on high dose of aflibercept. I wasn't able to get that data, but that's really what I would be interested in seeing. But they had a fairly high percentage of their patients in Pulsar that they classified as PCV, and it seems to work well. So I think high dose of aflibercept is a very reasonable option for patients with PCV.
Thank you. That's
Thank
all
you.
from me. Thank you.
Thank you, Dr. Joshua, and thank you, Dr. Vishali, for a wonderful lecture and discussion. In the interest of time, we need to move on to our next presentation, which will be by Dr. David Zhu, who will be speaking to us on the preferred anti-VEGF in a particular disease. I always get confused as to what particular drug to use in a particular disease. I hope that Dr. David will show us the way. Dr. David, please go ahead.
Before Dr. David starts, I request all the speakers to please stick to the timeline as we have a symposium following us. Thank you.
Thank you. Thank you, everybody. And it's a great pleasure and an honor to be here with everybody here for the International Ophthalmic Conclave. So my name is David Chu. We'll be talking about what anti-VEGF for what disease. And here are my financial disclosures. So as we all know, VEGF inhibition plays a critical role in the treatment of a number of retinal diseases, and it downgrades vascular permeability, neovascularization, and edema. And when we're looking at the market of what available anti-VEGF agents we have to treat our retinal diseases, we have Avastin, we have the first generation agents like ranibizumab and aflibercept, we have brolucizumab, which is not commonly used, then we have our second generation agents, faricimab and high-dose Eylea, and then more durable systems like port delivery system, eluting ranibizumab and biosimilars. And then we have a number of our diseases, macular degeneration, diabetes, main occlusions, and myopic CNV. So when we're trying to choose which anti-VEGF agent to use, as Dr. Yor had alluded to, we have to look at the mechanisms of action. Bevacizumab and ranibizumab are very similar. Ranibizumab is affinity matured, and it's a modification of the molecule made by the same company. And this blocks VEGF-A. Aflibercept is a blocker of all isoforms of VEGF-A, and placental growth factor, and faricimab with its dual bispecific antibody blocks VEGF as well as angiopoietin. And so when we're choosing anti-VEGF, there's two paradigms really to think about. One is if you're trying to achieve better drying, so a better visual or anatomic benefit for the patients, or if you're choosing reduced treatment burden. And if that's the case, then you probably are trying to go for longer discussion or longer extension, or maybe you're trying to go for both of those things. So we're going to first look at diabetic macular edema. All right, it's a common disease. And for us, when you're talking about this, the only study with level 1 evidence that shows any visual benefit that helps us discriminate the use between these drugs is the DRCR protocol T, at least to my knowledge. And this is classic data, which we're all aware of, which shows that aflibercept in patients who started off 20/50 or worse do better in the long run at a year and 2 years as compared to ranibizumab and bevacizumab at 1 year and only bevacizumab at 2 years. And it really contributes to this halo effect that aflibercept has in its superiority for drying. And it's extended not just for DME, but also for macular degeneration. People feel like this is overall a stronger drug and promotes this idea that patients exist in their own swim lanes. And so if you start off worse, 20/50 or worse, you end up worse. If you start off better in the treatment of the disease, you end up better. And that's also a paradigm of thinking that's pervasive, that really stemmed from Protocol T and others, classic studies like this. So when we're comparing first generation drugs as to the second generation drugs like faricimab, as Dr. You already mentioned, here in these second generation drugs, we're not seeing any visual benefits. We do see durability benefits and anatomic benefits. Faricimab in the pivotal studies was non-inferior to aflibercept every 8 weeks when it was given on a personalized treatment interval, a PTI, up to 16 weeks. And as was already alluded to, there are some biomarkers that suggest it also is better anatomically. There was better CST reduction. There was probably reduction in inflammation from the biomarkers of hyperreflective foci present in diabetic macular edema, as well as a reduced risk of ERM formation. And similar data was played out in aflibercept high dose, the Photon study phase 3. This is dosing on a PTI interval up to 16 weeks as well, as non-inferior to standard aflibercept, standard 2 milligrams every 8 weeks. So definitely in both of the second generation drugs, we're seeing a ability to extend the patients for a greater period of time. That's one of the key benefits, and I think what this generation of drugs is helping to change in terms of our practice patterns is our understanding that this extension beyond quarterly injections, less frequently than quarterly injections, is now a viable treatment modality for patients, right? And previously, when we were talking about the early years of anti-VEGF a decade ago, prior studies have really highlighted that ranibizumab was not suitable for quarterly treatment for macular degeneration and diabetic macular edema. Those patients, for example, in the PIER study, which is for macular degeneration, did not do as well with quarterly injections. And so that was something that pervaded our thinking modality. And finally, I think we can comfortably, these agents give us credence that in the treat and extend era, which is how we typically, at least in the United States, treat the patients, we can safely and comfortably extend the patients beyond 12 weeks, beyond quarterly, with both the new injection medicines or maybe with the old ones as well. Another way of gleaning evidence of how you should inform the treatment of these with a selection of the drugs is through switching studies. And there's been reviews of various switching studies, which basically patients with diabetic macular edema receiving another type of drug that were switched to, in this case, faricimab. A number of studies in the USA and Japan have demonstrated in these retrospective series, so this is lower quality of evidence, that there are various types of advantages: better drying, greater proportion of patients with better vision, and better ability to have extension with fluid-free maculas. And so these are some of the benefits that you can see. We'll switch gears and talk about macular degeneration. And in all of these diseases, we can draw parallels between all these diseases, between DME and macular degeneration. Probably the VEGF load in macular degeneration is lower than that of DME. And this has been evaluated based on vitreous sampling of VEGF concentrations. It's probably because VEGF is expressed in wet macular degeneration only at the CNV, whereas in DME, it's diffusely through the hypoxemic retina. And so concordant with this, no high-level studies with high quality of evidence, pre-specified endpoints in large randomized trials have demonstrated any visual benefits between the anti-VEGF agents for wet macular degeneration. There are no visual benefits, but there are anatomic benefits and there is extension benefits. So when we look at this second generation drug, faricimab, these studies support higher fluid-free intervals, their ability for better drying in aflibercept resistant patients, better reduction in PED height. And these are exactly the same parallels that we saw 10 years ago when aflibercept switch studies were identified. They found better drying, better reduction in PED height, more ability to dry treatment-resistant ranibizumab patients, et cetera, and et cetera. And these are some switch studies in the USA which highlighted those same exact things: reduction in the better anatomy, reduction in PEDs, better extension. And so I want to talk about some general switching tips. This is kind of the same thing and gets to the question earlier as well, which is when you're talking about switching, before you declare treatment failure of the first drug, at least with us, and if, in the idealist of situations, you want to try at least 3 monthly loading doses. And in certain diseases like DME and RVO, you might consider up to 6 monthly doses before declaring a treatment failure with the first drug and continuing at the same interval for 3 doses before considering it a switch failure, a failure of the second drug. And if you're really going for not just extension, but you're going for drying, right? You probably want to return to monthly doses of the new drug if that's possible. That's in the ideal situation. And you want to monitor for adverse events. IOP is one of them. Aflibercept 8 milligrams is a higher volume. There's been some reports of higher IOP after faricimab. RPE tears and macular degeneration has always been a concern. There's been no study demonstrating any differences in the incidence of RPE tears between the drugs. However, that's always been a theoretical concern with more powerful drying agents. This is true for aflibercept when people, first started using the drug. This is true of faricimab and Eylea HD. Those with large serious PEDs, there should be some caution. There probably should be some discussion with the patients when you are treating these patients. And then there's increased risk of inflammation, which is something that we are all familiar with these days. And so the durability play with the second generation agents. The phase 3 studies, again, just like in DME, were evaluated out to 16 weeks and were non-inferior in terms of vision. There was better drying of some of these drugs. And finally, we would talk about one more way of extending durability, the port delivery system, the phase 3 Archway and the portal extension study. So these are patients that received Q24-week refill exchanges. So beyond extension to 16 weeks, we're talking about extension out to 24 weeks at high quality data here. And with these patients, non-inferior visual acuities when they receive ranibizumab port delivery system as compared to standard monthly ranibizumab. And 95% of these patients did not require any supplemental anti-VEGF injections. So that's a great durability play. And the future is going to be probably yet even brighter with alternative mechanisms, as Dr. Shah had mentioned, such as TKIs, gene therapy, and other things. Now, when we're talking about vein occlusions, this is overall less studied. There's less evidence about the differential effects between the different anti-VEGF agents. But when we draw these parallels, probably the VEGF burden is higher in the acute phase of an ischemic RVO, but it's probably biphasic. In the chronic phase, when the disease is well treated, then the VEGF load probably reduces. And clinically, that's concordant with the idea that some of these vein occlusion patients, they can be extended to a very large period of time and followed on a PRN basis. And so with that, we can use those parallels to inform our decision-making and the selection of the drugs between that of DME, wet AMD, and the vein occlusions. For myopic CNV, finally, at least in the United States, ranibizumab is the only FDA-approved therapy, and off-label bevacizumab is, of course, used very frequently. But typically, unfortunately, the treatment course for myopic CNV is usually limited, and patients need, oftentimes, in the range of 1 to 3 injections before that lesion regresses, fortunately. And so with that, that concludes my spiel about what anti-VEGF for what disease. Thank you all so much. It's a pleasure again being here. Thank you all.
Thank you, Dr. David. I request Dr. Munabende to discuss Dr. David's perspective.
Thank you, Dr. Zhu. It was a very nice overview of the treatment options. I would just like to ask you 2 questions. In the real world, we often have, especially for a type 3 MNB, you have the early stage where there's just an intraretinal proliferation and a cystoid macular edema, reasonably good vision. In that case, we would be looking at safety, more important, and not really looking at durability because these membranes vanish quite well. In that case, which would be your first option?
Yeah, I'd probably echo what others have mentioned already. For me, probably the first choice would be, I prefer ranibizumab or I prefer bevacizumab. And I know they're older drugs at this point, but like you said, safety is really good. The risk of inflammation in these drugs is extremely low, at least for me, in my experience, as compared to aflibercept. And they're well covered by insurance, which is really a practical concern. And so for those reasons, that's oftentimes a first starting point. It is uncommon for me to, in the cases where there is really mild evidence of exudation, so type 3 or like an early type 1 or type 2 lesion, and you get that feeling, patients are still 20/30 or better. You get this feeling that probably they don't need a big gun, and I'm usually not reaching for faricimab or Eylea HD in those typical cases.
And what about the very high pigment epithelial detachments where we are always worried about a rip? Is there any role of starting with, say, just Eylea and then moving to Eylea HD later on once it kind of settles?
Yeah, that's been a topic perennially of debate over here, and so many things have been tried. I have to say that over the years in my practice, I've just gotten more and more aggressive. When I first started, I would be using half dose bevacizumab for these patients and injecting them and seeing what happens. And I think that sometimes what we end up doing is we are undertreating these PEDs, and you almost see them increasing in size as you're being cautious with them. I don't go in and inject faricimab or high dose aflibercept, certainly, but I do feel comfortable treating them with standard Eylea, aflibercept or ranibizumab. Those are probably my go-to medications for this. That would be my suggestion. I think the data suggests that, there's really no difference between them, but again, caution and common sense prevail here.
Would I be right in summarizing that in DME, aflibercept is probably the preferred choice, and in AMD, you would want to switch to a newer agent if it is resistant to the disease?
Well, I'm sorry, I'm not sure if I fully heard your question. I think there's some audio issues, but I would suggest that, yeah, DME is probably a more difficult drug to treat when we're talking about the VEGF burden, and that's something that you have to really think about in the long term. So, I think that, unfortunately for us over here, I really don't prefer to start patients on ranibizumab 0.3 milligrams for DME. I do think that the Protocol T study really does show the superiority of these higher potency anti-VEGF drugs. So that's probably an area that's fallen out of favor. Unfortunately, with step therapy, as was alluded, I'm finding myself using an even less potent drug, bevacizumab, for DME patients, but that's outside of my control. And if the patients are doing well, they're doing well. Ultimately, what prevails above all these other, theoretical concerns and all these studies is the real world, and what prevails is the treat and extend regimen. So if they do well and they're just getting, Avastin, then that's fine.
Sure. Thank you. Thank you so much, Dr. Javichu and Dr. Munna. We'll move on to our next presentation, which will be by Dr. Meera Sivalingam. She will be speaking to us on the role of anti-VEGF in ROP. Dr. Meera.
Yep, so let me just share my screen here. Oops, sorry. Can you all see my screen?
Not yet. Yeah, we are able to see now.
Okay. Okay. So thank you so much for the organizing committee for having me here for this great symposium. I'm going to talk to you guys about the role of anti-VEGF medications in retinopathy of prematurity treatment. Here are my disclosures. So we know that retinopathy of prematurity is a retinal vascular disease that we see in premature infants, and it occurs in infants who are born prior to retinal vascularization completion. Stage 1 is a demarcation line. Stage 2, we have a ridge with some height that evolves from the demarcation line. In stage 3, we have extraretinal neovascular proliferation that can extend from the ridge out into the vitreous. Stage 4 is when we have a partial retinal detachment, either sparing or involving the fovea. And then stage 5 is a total retinal detachment. And the important thing in this slide to note, and it's very important for our discussion of anti-VEGF medications, is aggressive ROP or APROP. And this is a disease where you have prominent plus disease, you have an ill-defined demarcation line, as well as a flat network of proliferating neovascular vessels, is often difficult to differentiate between arterioles and venules. And the progression of the disease does not follow classically through stages 1 through 3. So even for the most experienced screeners, it can make this difficult to pick up in a timely manner. And here's our standard screening schedule starting at 22 weeks gestation, going up to 30 weeks. And the length of screening, babies are screened according to our schedule and then are followed until they either have normal retinal vasculature or they confirm to have regressing ROP. If the babies do receive treatment, either injection or laser, they are standardly regulated to have regular exams up to 84 weeks gestation. So let's talk about treatment. The treatment for this difficult disease has really evolved drastically over the last 50 years. Our first real treatment for this disease was cryotherapy, which showed rather modest efficacy, especially for treating posterior disease in zone 1 and posterior zone 2. And the anatomic and visual outcomes did not show a significant improvement. And then in the late 80s and early 90s, laser ablation was established as the standard of care and is currently the gold standard for treatment in these patients. And now we're lucky enough to be in the era of anti-VEGF medications for retinopathy of prematurity. So BEAT-ROP or BEAT-ROP was our first major study looking at the use of anti-VEGF medications in the treatment of retinopathy of prematurity. So the enrollment criteria for this study was a birth weight less than 1,500 grams with an age of less than 30 weeks gestation. And the intervention was a half dose of the adult, so 0.625 milligrams versus conventional laser bilaterally. And the overall outcome of this study showed a lower recurrence in stage 3 ROP with bevacizumab versus laser. So this really kind of opened the door for the use of anti-VEGF medications for the treatment of retinopathy of prematurity. So if we know that laser is fairly effective, why consider anti-VEGF? So there are limitations to use of laser. There is a significant need for a fairly large infrastructure and equipment investment for laser ablation for these babies. The anesthesia burden for laser treatment is often significant. In our hospitals in the Northeast here, we try to do most of these laser treatments under IV sedation. However, oftentimes these babies have a lot of other medical comorbidities and intubation may be required. We know that intubation for these treatments can prolong the NICU stay for these children. Laser application requires highly skilled training for proper laser technique to minimize the risk of recurrence. And then for zone 1 and posterior zone 2 disease, as well as APROP, the visual and anatomic outcomes with laser ablation is much poorer. So this is just a summary looking at some of the earlier anti-VEGF trials, mainly looking at bevacizumab and ranibizumab. And what we can take away from this slide is that we know that anti-VEGF treatment for retinopathy of prematurity regresses the disease with injection. With these medications, safety is always a concern, especially in neonates with a lot of other medical comorbidities. Unfortunately, we don't have a lot of long-term data looking at the effects of neurodevelopmental delay in these neonates. Lian et al. In 2016 had a small retrospective study which had a duration of 2-year follow-up that showed no significant difference in neurodevelopmental delay between babies treated with laser versus bevacizumab. And then Morin et al. In 2016 had kind of a different outcome. They found that there were significantly higher rates of neurodevelopmental delay in the bevacizumab arm. However, This arm wasn't well matched, and these babies kind of overall had other medical comorbidities that may have muddied the water for the data. So what agents do we have? So mainly we use bevacizumab, aflibercept, and ranibizumab. We'll start with bevacizumab, and it was the first one to be used. It's obviously an off-label medication, and it's widely used for ROP. Our dosing is half of the adult dose, so 0.625 milligrams in 0.025 cc's. We know that it has good efficacy, especially for severe zone 1 and posterior zone 2 disease, and it is relatively cost effective. Next, we have aflibercept. It was actually FDA approved in the United States for use in ROP in 2023. And the dosing for aflibercept in neonates is 0.4 milligrams or 0.01 cc's. The one thing that makes using aflibercept a little bit more difficult, and you have to be very careful in administration, is that the volume is very, very small. So this is just a diagram kind of, highlighting the importance of, looking at the CC markers very carefully prior to administration, pushing out all the bubbles and pushing out the medication to the 0.01 ml line. Otherwise, you risk either putting too much medication into the eye or not getting enough. And then we have ranibizumab. This has a smaller half-life, and there may be less systemic effects. Again, this is an off-label use, and the dosing is 0.2 milligrams 0.2 milligrams in 0.02 milliliters. The one drawback of ranibizumab is that some studies may show that there's higher rate of recurrence. Administration for these medications in these neonates is very, very different than in an adult. So these medications, especially if they have bilateral disease, can be administered in both eyes on the same day. Anesthesia. Typically, these patients can be given either topical proparacaine or tetracaine in conjunction with a little sweetie pacifier. Sometimes limited IV sedation may have to be used. In terms of antisepsis, very important. We know that, these settings in the ICU, there's a high rate of bacterial colonization on the skin and in the conjunctival sac. So we can use povidone iodine 5% and 10%, as well as chlorhexidine 0.05 or 0.1. We recommend that everyone who's involved wears a mask and sterile gloves, and very important to use a sterile lid speculum. So we know that the anatomy of a neonatal eye is very different from an adult's, and it's just less than a third of the adult eye in terms of the axial length. And the size of the lens relative to the rest of the globe is much larger. In addition, the pars plana is often very underdeveloped. So the window for administration of this medication into the vitreous cavity is much smaller than an adult. So we want to make sure we measure very carefully about 1 millimeter posterior to the limbus, and we're making sure that the needle is pointing towards the optic nerve to avoid any chance of lens violation. In terms of what needles to use, so I like to use one of these two needles. The top choice is a 32 gauge 4 millimeter TSK hypodermic needle. And the nice thing about this needle is it's shorter than our standard half-inch needles, and you can actually hub the needle without risk of hitting the retina on the other side. If you do not have this available, you can use a 30 gauge half-inch needle, and we recommend you insert this needle about a third of the length of the needle into the vitreous cavity. It's very important to have good globe stabilization, different from an adult injection where you have their participation in stabilizing their own eye. These neonates are, don't have control over their eye, so I often use either a sterile cotton swab or 0.12 forceps. Good head stabilization with a skilled assistant can be very helpful. And then importantly, indirect examination following administration to confirm that the medication did make it into the vitreous cavity. There's no hemorrhage, there's no retinal detachment, and we have a patent central retinal artery. Now, obviously, there's no evidence behind this, and there's no real standard, but typically most physicians prescribe topical antibiotics for 5 to 7 days following the injection. So let's talk about recurrence when we're using anti-VEGF medications. Don't really need to get tied up in the details of this table. All we need to know is that recurrence is a risk when we're using anti-VEGF medications for retinopathy of prematurity. So we know that initially after treatment, anti-VEGF can result in good initial regression, but often these neonates require repeat injections either a couple weeks or a month or two after the initial treatment. And late recurrence, even up to 5 years following treatment, has been seen. Often a big consideration is these patients often have other very complex medical conditions, which may limit their ability to maintain close follow-up, especially once they are discharged home out of the neonatal ICU. Other considerations to take into account, urban versus rural settings. If you're in an urban setting, it may be easier to have closer follow-up for these patients following anti-VEGF treatment versus a more rural setting. You may have very limited access to that patient. And in that setting, you may want to consider laser ablation. There's other social considerations that can also often limit good patient follow-up, especially when they are discharged home. Looking at, we know that when we treat with anti-VEGF medication, it regresses the retinopathy prematurity. And we do see continued development of the normal retinal vasculature. However, often these neonates often have residual avascular retina. And the question is what to do with that. So Al-Rashid et al., excuse me, in 2022 looked at the persistence of avascular retina in these neonates, and at on fluorescein angiogram that was performed between 155 to 288 weeks post-menstrual age, they found that most of these babies had more than two disc diameters of persistent avascular retina. And more importantly, babies who were treated with a history of APROP were more likely to have persistent peripheral neovascularization. And especially in these cases, this may indicate that laser to the avascular retina may minimize the rate of recurrence. I think that there's still a lot to learn about the use of anti-VEGF medications in retinopathy of prematurity. We don't have a lot of long-term data, and they're rather limited prospective studies. But I think we're going to learn a lot more in the next 5 to 10 years, especially as these neonates that are surviving at earlier and earlier gestational weeks. We're going to be able to see how these neonates do long-term into adulthood. So that's all I have for today. Thank you guys so much for having me.
Thank you, Dr. Meera, for a wonderful lecture encompassing all the aspects of using anti-VEGF in ROP. Dr. Rohan, can you discuss this presentation, please?
Yeah, thank you, sir. And thank you, Dr. Meera, for a nice presentation. So just a question for you. Like you said, we can have 3 options, 3 drugs which we can use. So considering all in the real world, considering the social, legal, and economic parameters, which one is your preferred agent at present for a case of, say, APROP?
Yeah, it's a great question. So, in my practice, I still adopt, laser ablation is my gold standard if they have, zone 2 disease, stage 3. But for, my APROP babies, usually I use aflibercept. However, there are some situations where aflibercept is not available. And so I will use bevacizumab. I've had, very good experience with aflibercept, usually get a very good response. The one thing to be cautious of is that the volume is very small. And I think it is very easy to underdose because the volume is very small. So that is one drawback, whereas, treatment with bevacizumab, the volume is a little bit larger, 0.0, 0.02 cc's versus 0.01. So that's, one drawback to using the aflibercept. Sometimes I will, leave a little bit more in the syringe just to ensure that enough got into the vitreous cavity to ensure a good response.
So in our experience, considering the cost and also the legal issues, we are doing slightly differently. At least at our center, we are more using ranibizumab and even ranibizumab biosimilars. Although bevacizumab definitely probably has a longer lasting action, less of recurrence, but still because of the various issues, we are still using ranibizumab, and the injection volume is definitely a big issue with aflibercept and the cost.
Yes, definitely. Yeah, I mean, I think bevacizumab is a great option. It's much more cost effective. So, that's a good option.
And we are also using these anti-VEGF agents post-surgery. Some of these stage 4A or 4B, once you operate at closure, again, sometimes we are injecting the anti-VEGF agents just like they might be helping in a diabetic vitrectomy or something like that.
I have a
Any-
question for you guys. How often are you treating with anti-VEGF and then lasering them before they leave? Because that's often what we do in our practice. I know, practice patterns, even within the Northeast in the US, are very varying depending on your institution.
So from my experience, definitely with ranibizumab, we do have a lot of babies who definitely have a persistent avascular retina left over, even if we give them a lot of time for the vasculature to progress. And yes, about 70% of them do require rescue laser or just a laser to cover the peripheral avascular retina later on. But others, Dr. Mahesh and others, please might add from their experience.
I would agree. I think we are trying to save as much retina as possible, extending the normal vascularization to go at least beyond zone 2 before we intervene and then do the laser. So most of our patients will need laser because as the children become older, it becomes difficult to examine them in the outpatient easily. And what is different in India is like the laser as well as the anti-VEGF is done under topical anesthesia. So we don't give general anesthesia for doing laser as well. So that's one thing different. So thank you so much, Dr. Meera and Dr. Rohan. And now to give us the Indian perspective, I invite Dr. Raja Narayanan. Dr. Raja will be speaking to us on the Indian perspective.
Yeah, thank you. I hope my slides are visible and I'm audible.
Yes, Dr. Raja.
Thank you once again, Dr. Shanmugam and Dr. Garg for this opportunity. It's been great listening to the previous speakers. So my talk is a collection of short stories on the Indian landscape of anti-VEGF, and I would like to acknowledge the past and present office bearers of ASRS-VRSI and many other individual collaborators that I have listed here. The global anti-VEGF market for retinal diseases runs into billions of dollars, but to give a perspective, anti-VEGFs account for anti-VEGF inhibitors account for the highest cost drugs for US Medicare, actually. Part B, among the top 10 drugs spent in 2019 or 2020 in the US Medicare, 3 were anti-VEGF drugs. So among all specialties, so that's the amount of, you can say the importance of value of anti-VEGFs that is there in terms of economics. In India, the national health insurance, government insurance does not cover these drugs yet, but many of the state insurance programs cover these drugs. Let me just advance my slide. Oops. Yeah. So as the first part of short story, the adherence rate or compliance to intravitreal injections is something which has been really concerning for us because the insurance has not been covering these drugs for a long, long time. So we looked at the adherence to the prescription of intravitreal injections In out-of-pocket patients, insured patients, and non-paying patients at LV Prasad Eye Institute, where we fully subsidize these patients. So what we looked at was the proportion of patients who actually received the injection compared to those who were actually advised an injection. This was done across all the centers of LV Prasad Eye Institute, where we give these injections in our tertiary centers. More than 50,000 patient data were retrieved from the electronic medical records. But if you see the the yellow highlighted row, the first one. So among the self-paying patients who pay out of pocket, less than 50% of patients actually take the injection when they are advised an anti-VEGF injection. Surprisingly, even the non-paying patients who are given the injection free of cost, also the compliance rate is just about 60%, whereas among the insured patients, it was 100%. Now, this poses a lot of questions to us, and with this in mind, we had worked out when I was in the office of VRSI, we had discussed with the private insurers, the IRDA, the regulatory authority, as well as various other agencies. We worked with the actuarials and looked at the cost of including intravitreal procedures in private insurance. So looking at this treatment funnel among 1 million patients who are there as a base, who have the policy of these insurance, assuming 3 injections per year as the average in the real world, the number of intravitreal injections and the cost, when we calculated the additional premium which the policy holders have to pay, turned out to be just rupee 28 per year. In terms of US dollar, it's probably about 25 cents or slightly more per year for each policy holder. So we worked this out, and finally the private insurance was given the mandate to allow intravitreal injections, not just allow, but not to exclude intravitreal injections for our patients. But this happened only in October 2020. So it was very late that intravitreal injections got approval in India among the private insurance. Then the other short story which I would like to tell is about the biosimilars. India was the first country to approve ophthalmic biosimilar, that is the ranibizumab biosimilar. And more than 50, probably many more biosimilars are now available in India, not for just ophthalmological use, but across different specialities. But at least India was the first to approve a ranibizumab biosimilar. And when we look at the data, way back in 2017, which was just after the biosimilar was approved in India, biosimilar usage was very slow to pick up in India. If you look at the top right box here, less than 5% of the retina specialists were using biosimilars when you looked at the overall anti-VEGF usage. And then in 2021, when we published the use of anti-VEGF biosimilars in India, based on a 2020 survey, this biosimilar usage increased to 20% from about 5% in 2017 to 20% in 2020. And the more recent publication by Ashish Sharma, along with VRSI and other collaborators, they have shown that in India, less than 25% of retina specialists now use the original innovator molecule of ranibizumab, which is Lucentis or Eccentric. So less than 25% of India retina specialists now use the original molecule. And in fact, more than 50% actually use exclusively ranibizumab biosimilars. So what's the US connection to this? The US Congress passed a law way back in 2010 during Obama administration's first term, which was the BPCI Act, allowing for biosimilar manufacturing, but we looked at its impact in India. So we did complete analysis along with our collaborators in business schools as well as economists. And what we found that is that when this law was passed in the US, the Indian landscape changed, and the number of firms manufacturing biosimilars in India increased significantly across the different zones of India, and the prices of the biologics started reducing in India. So this is a tremendous reduction in the prices of biologics in India because of that particular act being passed by the US Senate. And I will come to the specifics of that. And if we look at the sales or volumes of the number of injections being sold by the first ranibizumab manufacturer, Intas, from about 600 injections a month in 2017, they are now selling more than 15,000 injections per month. And in the last 1 year, there has been a 40% growth in the number of ranibizumab biosimilars that they are selling in India. What about the individual price cost, both as a treatment cost, as an injection cost? So when ranibizumab was launched in India as Lucentis, it was priced very similar to the US price. And here in this column, I have compared the cost of treatment per year to the GDP, the gross domestic product of India and US. I would like to just concentrate on this ratio here. In India, the cost of treatment for AMD or diabetic macular edema was 3 times the annual GDP of India, or 300%. So patients would have to shell out 3 times their annual income on average for a 1 year treatment of AMD or DME, which is impossible. It's just theoretical. Practically, it's not possible. Whereas in the US, it was about 30% of the GDP, the annual treatment cost. And that's covered by insurance in the US. So what happened after the ranibizumab biosimilar was launched and the effect later on in 2023, the innovator original Lucentis or Excentrix molecules price dropped in India drastically, whereas in the US it more or less remained the same. And India's GDP also kind of doubled. Even the US GDP has doubled. But if you look at the proportions, from about 300% of the annual GDP, it came down to just 17% of the annual GDP for the Indian patients. This became much more affordable. And if you look at biosimilar ranibizumab pricing, the treatment is just about 5% of the annual GDP of an average Indian. So an Indian can now expect to pay just 5% of their annual income for the treatment of an annual AMD or DME. Even the US prices have come down. This is a patient who came just a few days back to me who had received Macugen. This is a forgotten drug. In fact, this was approved even before Lucentis, but it fell out of favor. But it was used for a brief period of time. So this patient had a central retinal vein occlusion 17 years earlier, and you see, at that time, this patient had paid more than $1,000 per injection. And this time for his branch vein occlusion, 17 years later, in the right eye, he is paying only about $150 per injection. This is more than a tenth reduction. And we had paper records, electronic records. Now that's one difference that you can look at. And this was another patient way back in 2011 when photodynamic therapy was commonly used. Along with Lucentis, this patient was paying more than $2,500 for one session of treatment, whereas this patient just recently had received a razumab injection or ranibizumab biosimilar. Again, the cost has been just $150 an injection. And on the right side, you see the number of injections this patient has been receiving and this tells the story of affordability now. We also have done work on looking at the recent or
Dr.
relative.
Sorry to interrupt. Will it be possible to speed
Yes,
up a little bit?
I'm just coming to the last couple of slides now.
Sure.
So
Thank you.
this is the work which we have looked at the Inflation Reduction Act, which looked at biosimilars and the negotiation price for the US. In India, the aflibercept biosimilar probably is the first going to be launched in the Indian market by Zydus. It is expected in Q3. You can see the recent story of just a few days ago where another biosimilar has been approved in the EU, and this has made this affordable for our secondary centers, rural centers as well, the 80% compliance rate which we have achieved now with this affordability. And the story does not get completed without this Avastin ban role, where we had a lot of collaboration with AIOS, VRSI, as well as ASRS to reverse this ban, and we published this earlier. So in conclusion, the introduction of biosimilars has played a major role in the price reduction of many molecules, including the recent ones of faricimab, brolucizumab, and government insurance in many state and also private insurance companies reimburse it, and patients are sure to benefit in the future. And international cooperation has played a major role in the anti-VEGF landscape in India. Thank you very much for your kind attention.
Thank you so much, Dr. Raja. I invite Dr. Muralidhar for brief comments, please.
Yeah, thank you, Raja. That was a brilliant summary of the Indian scenario of the anti-VEGF therapy. As you have rightly pointed out, the approval of the insurance companies for giving the anti-VEGF therapy was a major breakthrough, which really helped us in treating many patients. And the introduction of biosimilars also definitely brought many patients affordability, to a better level, and therefore we are able to now treat these patients. And thirdly, I also want to touch upon the fact that the other two new molecules, the faricimab and the aflibercept, the companies also recognize that the Indian scenario is different, and they are also able to support with a patient assistance program. And that also brings down the cost of the treatment for those patients who can still afford it to a much better level. So considering all this, I think now the Indian patients are in a much better situation compared to what they were earlier in terms of having to undergo the anti-VEGF therapy. But still, having said all that, with the introduction of biosimilars and the insurance and the PAP program by the various companies, I still believe that for our population, for the Indian population, bevacizumab should remain the first drug of choice for the treatment for our vast population, whether we are treating AMD, whether we're treating DME, or whether we're treating other diseases where anti-VEGF therapy is required. I still feel that bevacizumab is the drug of choice, that we need to use in India, considering the economic situations. I don't know how the others feel. I would rather welcome their views also on this.
Thank you, Dr. Murli. In the interest of time, I can't welcome the other people's views. I'm sorry. So I would like to go on to our case presentations. Dr. Meenakshi, can you go ahead with your presentation, please?
Yes, sir. Are my slides visible?
Yeah,
And
they
I
are.
hope
Please
I'm
go ahead.
audible.
They are visible.
Okay, good evening, everyone. Thank you for this opportunity. I'm going to be talking about when only anti-VEGFs didn't work, what did we do? This is the case of a 64-year-old lady who presented with 6/9 N6 vision in the right eye, and her left eye vision was 6/60 and N36. She'd undergone an FFA ICGA elsewhere. The right eye showed a branching vascular pattern, and the left eye showed a polypoidal lesion. Treatment was deferred for the left eye due to disciform scarring. Over the next 1 year, the right eye developed multilobulated PDs with double layer sign and recurrent subretinal fluid. The PD height was significantly high, even with recurrent SRF, even after 3 doses of aflibercept. So we gave a trial of aflibercept plus intravitreal triamcinolone. The subretinal fluid resolved and the PD height significantly reduced. She recurred in 5 months, however, and then we went ahead and tried the ranibizumab with a dexamethasone implant. She was status quo for 8 months. Considering the cost factor involved when she recurred again, a trial of only the intravitreal anti-VEGF ranibizumab injection was given. She recurred again in 4 months, and thereafter, every time she recurred, we gave her an intravitreal injection of ranibizumab with a steroid component, either IVTA or DEX implant. She remained stable for 5 months, and we went ahead with a trial of only an intravitreal DEX implant. However, the SRF persisted at 1 month, hence warranting the need of an additional anti-VEGF also, which was given. She remained stable for 3 months, following which the subretinal fluid persisted with the multilobulated PED height increase. We gave her a single dose of aflibercept, considering the cost factor again, where she showed a subnormal response. So over the next 9 months, she needed one injection of aflibercept in right eye almost every month. We were able to increase the interval to a maximum of 1 month with just the anti-VEGF, and for 2 months with a combination of anti-VEGF and steroid. The combination seemed to work for a longer interval at the beginning. So that's why we suspected a tachyphylaxis to aflibercept. So we gave her a trial of brolucizumab, where she maintained stability for 1 month between injections. And with the DEX implant and brolucizumab, she remained stable for 3 months. So we gradually increased it to about 4 to 4.5 months between the interval between the injections. And every time she recurred, we gave her a brolucizumab dose with the dexamethasone implant, with also a periodic subtenon steroid injection, considering the fact that it's her only eye and we didn't want any inflammation. So the last injection was given in November 2024, where we switched over to aflibercept with a DEX implant. And as of the follow-up in January 2025, she maintains a vision of 6/9, and her condition remains stable. So what did the combination help us achieve? Basically, a longer injection-free interval. The collapse of the PD was noted, preserving the vision in the only seeing eye. Stability for about 4 months with brolucizumab with dexamethasone implant, and stability for about 2 months with aflibercept with dexamethasone implant. The review of literature showed us a couple of studies, one which showed the dexamethasone implant, which improved the anatomical response to anti-VEGF therapy in treatment-resistant PCV, where 12 eyes were studied, and the central retinal thickness significantly reduced, and the median injection-free interval was about 5 months. The studies with neovascular AMD, however, were not so promising. Even if they showed significant response in CMT reduction, they did not maintain a significant response at later follow-ups of 6 and 7 months, and the visual acuity did not significantly improve. So my questions to the panel are, could we have tried any other modalities in recalcitrant cases like these? And if they have any experience with the combination of treatment of steroids and anti-VEGF in PCV. Thank you for your patient listening.
And thank you, Dr. Meenakshi. I request Dr. Sunir to comment on this case. Like we adding the steroids seem to increase the treatment intervals. Is there any such options which you would follow in the US?
Yeah, so there's definitely occasions in which people will do that. There was a recent report that came out looking at just that combination approach. But it's, at least in my hands, it's been a little bit more variable. And, it was kind of something that was of great interest maybe in the, 2008, 2012 era, where we were doing quite a bit of it. But over time, it didn't seem like it made much of a difference for most patients compared to anti-VEGF monotherapy. So it's definitely a uncommon procedure. Some of these eyes that have polypoidal, if they have that really big PED that this patient developed, toward the end of the slide deck, maybe I'd be a bit hesitant about doing PDT at that point. But along the way, once the PED is quieter, I've had good success in a number of patients in this scenario in trying to get them to be more stable without requiring as much, sort of variability in the OCT and in the vision.
So, Dr. Mahesh, I have a brief comment. Great presentation, Meenakshi. So, when you look at these patients in terms of their visual outcome as an outcome measure, the gain in vision, I don't think that's the correct parameter, because the natural history of the treatment, when you give these injections, after the first few injections, these patients are not going to gain any further vision. If you see any graph of any trial in retina anti-VEGF diseases, the first few months and then a plateau. So when you are intervening at that phase, all you are concerned is reducing the burden of treatment while maintaining the injections. So if if you start comparing a monotherapy and this, and then you say there's no difference in the gain in vision, if you are already treating a resistant case, that's not the correct outcome measure. That's where I think protocol U for DME also, I would have liked it to be looked at differently. But yes, in rare instances of resistant cases, this does work. It's not a routinely done therapy. Yes.
Thanks, Dr. Raja, for that's a great point. Can I invite Dr. Pradeep Sagar to present his case, please?
Good evening, one and all. Thank you for the opportunity. I will be discussing a few cases of diabetic macular edema. My first case is a 54-year-old lady with both a moderate non-proliferative diabetic retinopathy and right eye center involving diabetic macular edema. At presentation, her HbA1c was 10.6, FBS was 270. We advised an endocrinology consultation for systemic control. At 2 weeks, her FBS had come down to 120. We went ahead with the right eye intravitreal aflibercept, and this is at 1 month post aflibercept. And we decided to just observe the patient and advised her to control her systemic status. At 6 months, the HbA1c had reduced to 7.8 from the initial 10.6, and we can see that there was no recurrence of macular edema. In this case, the good response and lack of recurrence can be a natural history of the disease itself, or it can be partly due to the glycemic control that we could achieve in this patient. Our second case is a 51-year-old male with both a moderate non-proliferative diabetic retinopathy and left eye center involving diabetic macular edema. He did not respond well to bevacizumab, dexamethasone implant, and triamcinolone. On careful review, we could see that there was a red lesion with a white rim adjacent to the fovea, which was confirmed on OCT as a hyperreflective rim with a hyporeflective lumen. So this was treated with a laser, and the endpoint was blanching of the aneurysm. And here we can see that there was a complete sclerosis of the aneurysm, and the corresponding OCT shows a complete resolution of macular edema, and the patient didn't have any recurrence for the next 24 months. So this lesion, some authors described as telcaps, but we prefer to use the term retinal capillary macroaneurysm because these are aneurysms arising from the capillaries, but they are larger than the regular microaneurysm that we see in diabetic retinopathy. They can be identified by a careful slit lamp examination as a red lesion with a white rim, and it's aided by fundus photography and OCT. They respond poorly to anti-VEGF and they respond well to laser in most of the cases. Case 3 is a 55-year-old gentleman with PDR with chronic center involving DME. Here we can see that a similar lesion is present, and post-laser at 1 month there was a reduction in macular edema. At 1 year there is no recurrence. So I would like to conclude that a systemic control has a role in management of diabetic macular edema, and cases with a DME secondary to retinal capillary macroaneurysm, we should consider a prompt laser. Thank you.
Thank you so much, Dr. Pradeep. We had included these cases to show that like diabetic macular edema doesn't mean that we have to keep injecting. We have to look at other things like systemic control as well as telcaps or the retinal capillary macroaneurysm, which would respond better to laser rather than with the anti-VEGF agents or steroids. Thank you, Dr. Pradeep. We'll go on to our last presentation, which would be by Dr. Sri. Your slides are visible, Dr. Sira.
Yeah, once. Yeah. So going directly into the topic, as we know, we have several anti-VEGFs in retinal vein occlusion, which are few are FDA approval and few of them are off-label and few are still undergoing approvals under FDA trials. When we talk of an anti-VEGF regimen for any disease, it can be a proactive regimen where it can be a treat and extend or a fixed treatment interval, or it can be a reactive regimen which can be pro-renata or as needed after a 3 monthly loading doses and personalized treatment interval. I'll be going through few cases of a retinal vein occlusion with various anti-VEGF and various protocol. Coming directly to case 1, it was a case of a 49-year-old female who is hypertensive and presented with blurred vision in a left eye. So she presented with supratemporal BRVO with a center-involved macular edema. Her vision was 6/9. We advised an anti-VEGF, which she took 2 weeks later. What we can see it as 1 month, though the macular edema was clear, the patient still had a lot of hemorrhages and cotton wool spots. We had told that there can be chances of recurrences, and that's what happened. A month later, again, there was edema and drop of vision. So she took an injection again, and she was stable for a few months from March till September. That is close to 6 months she was stable. And in September, again, she presented with macular edema. So she required one more injection of ranibizumab. So here we had a case of a lady who took intravitreal ranibizumab with a PRN treatment status. When we see this close to 1 year, the patient is not happy. So PRN treatment, we can say works initially, but might come back again. Case 2, a 55-year-old hypertensive and diabetic presenting with central retinal vein occlusion with a macular edema. Her vision at presentation was 6/18. So she received an intravitreal biosimilar, ranibizumab biosimilar on 20th September. Though we advised her, she took a long gap to take the treatment. Post-treatment, she was happy. Her vision has improved at first week following the anti-VEGF visit. However, a month later, again, the edema rebounded. Again, we have advised an anti-VEGF, which she again took at 2-week interval. Again, the edema has come down. But the story continues. Again, at 6-week interval, there is a recurrence of edema, and she took an intravitreal injection again. So in case 2, we have a lady who has taken an intravitreal ranibizumab biosimilar. She took an Osiva injection at almost a loading type of regimen every 6 weeks. Again, this is a short follow-up, though 4 months, but what we can see is the edema is still recurrent. In case 3, a 38-year-old male with hyperhomocystinemia and past history of brain stroke secondary to hyperhomocystinemia. He presented with sudden onset of central scotoma in the left eye. He had an inferior hemiretinal vein occlusion with a BRAO. He was very symptomatic, and disc was hyperemic and appeared to be congested. So we gave an intravitreal injection of biosimilar, ranibizumab biosimilar, which the patient took on same day. This patient has come on several follow-ups, close to 8 months follow-up. We can see that the patient has beautifully responded with the control of the hyperhomocystinemia. There is no sign of any vein occlusion at present, though there is thinning of the retina secondary to the branch retinal artery occlusion. So just to summarize, we have 3 cases, different strategies, PRN, fixed interval injections, or a single dose. Unfortunately, we don't know which patient will be, completely cured and which patient will come back with recurrence. The main reason for this being various systemic and ocular risk factors involved in a vein occlusion. So just when we analyzed real world outcomes in retinal vein occlusions, whether we are giving an initial monthly loading doses and treat and extend, or loading doses followed by PRN or PRN from beginning, usually BRVO cases showed a good outcome while CRVO was not that great. So I just want to ask the panel, what is best for patient in such conditions, considering it's a disease which has various systemic risk factors, ocular association, chances of patient compliance being poor, and drug tachyphylaxis.
Thank you, Shira. In the interest of time, I think we will request Dr. Lalit to answer your questions and also give the concluding remarks. Dr. Lalit Verma, please.
No, time is over, but in any case, it was a great webinar, and I thank all who, spoke very well, and I think everybody who attended gained quite a lot. Future for our patients, I think, is definitely bright, if not for retinologists, as Chirag had said. And 5 great, wonderful talks and 3 cases, were a great learning exercise. And thank ASRS-VRSI, Dr. Sunil Garg, and the entire ASRS for, being present here at different points of time. Thanks once again, everybody.
Thank you, Dr. Lalit. Thank you, Dr. Garg and the ASRS team for being with us. Thank you so much, and good night and good morning.
Thank you, doctor.
Yeah.
Thank you,
Bye.
doctor.